I'm Dr. Karen Michell, the Research Program Manager Lead for Occupational Health here at IOSH. It's my pleasure to welcome you to this webinar, where our esteemed panelists will share the initial findings from 4 years of hard work on the Mental Health Promotion and Intervention in Occupational Settings project, known colloquially as MENTUPP. I will not go into any detail at this stage for fear of stealing their limelight, as they say, but suffice for me to say at this stage that it has been my absolute pleasure to have worked with this collaborative team of researchers on the MENTUPP project, a significant project with the potential to positively affect workers' mental health. The webinar is also well timed as we acknowledge World Mental Health Day this week. Just by way of a statistic, in 2019, the WHO reported that 1 in every 8 people, or 970 million people around the world, were living with a mental health disorder. In 2020, the number of people living with anxiety and depressive disorders rose significantly because of the COVID pandemic, many of whom are workers. So before we start the webinar, I'd like to start with a few housekeeping issues. All audience members, of whom we have over 500 registered for today's webinar, have been muted. You are, however, invited and encouraged to ask questions through our Q&A box and not in the chat box. In addition to this, the audience members have the possibility to actually vote for a question that they like and would like to see answered. At the end of the session, we will then address the questions that have been posed. So, without any further ado, let me introduce our speakers to you. Based on our time constraints, I will briefly introduce these speakers, all of whom have very impressive CVs. So please, I encourage, if you would like to see their CVs, just let me know. As I have said, there will be 4 speakers, so 4 presentations, and question and answers will follow after each of these. Our first speaker today is Professor Ella Arensman. Ella has conducted research into a wide range of topics relating to suicide, self-harm, and public mental health. In her position as research professor with the School of Public Health and chief scientist with the National Suicide Research Foundation at the University College Cork, she has established an extensive research program in suicide prevention research and public mental health, based on a long-standing track record of successful funding awards. She has more than 200 publications and numerous other outputs. Ella leads a multidisciplinary research team, including staff members from public health, psychology, psychiatry, primary care, and occupational health. Ella, if I can ask you to put on your camera, and welcome.
Thank you very much, Karen, for that very kind introduction. Yes, so thank you again, Karen, and also thank you for all the participants here on the call today. And a big thank you to IOSH for organizing this great webinar here in conjunction with World Mental Health Day. I'm also very pleased to be joined by a number of key partners of the MENTUPP Consortium who will provide you with some further details about specifics around the methodology, the implementation, but also I'm very pleased that today we can share with you first outcomes of the MENTUPP intervention study. So I will just give a brief overview of the outline of MENTUPP, a few historical points, because we are currently close to the finish. We are over 3.5 years in this 4-year project, which is funded by EU Horizon 2020, and which is a very large consortium comprising 18 partners across 11 European countries and also Australia and the US. I'm very pleased to say that the consortium represents a truly interdisciplinary approach with partners from occupational health, psychiatry, psychology, biostatistics, implementation science, and so forth. And I think that's absolutely a must to be able to achieve a project that very much focuses on both development, implementation, and evaluation in mental health promotion, suicide prevention in the workplace. So overall, the main project aims are to improve mental health in the workplace by developing, implementing, and evaluating a multi-level intervention program, whereby in this instance we have particularly focused on small and medium enterprises, and I will say a little bit more about that. Secondary aim, importantly, is to reduce depression and suicidal behavior, particularly via the use and the access to the MENTUPP Hub, which will be explained later on as well. We have in MENTUPP decided to approach SMEs in 3 target sectors, so healthcare, information and communications technology, and construction. And I will say a little bit more about the rationale behind that in a few minutes. Here you see a systematic overview of the specific objectives, which in MENTUPP also related to the specific work packages aligned with achieving the goals of developing the MENTUPP Hub, implementation, and also evaluation. The unique aspect of MENTUPP is that we very specifically distinguished between developing resources to target stress, burnout, well-being, and depressive symptoms, where I say the non-clinical mental health conditions, and then secondly, to address depressive disorders and comorbid anxiety, specifically the clinical mental health conditions or disorders. And then we also have developed specific resources in terms of tackling stigma in the workplace, which was really a cross-cutting resource, also very strongly represented in the MENTUPP Hub. I think that MENTUPP is one of the first consortia and MENTUPP Hub the first resources to really make that very specific distinction. Across the different other work packages, then we step-by-step developed the MENTUPP Hub, the MENTUPP intervention. We had a 6-month pilot study, of which you will hear some outcomes here today. And we have recently completed, and I'm very pleased to say that, a 9-month cluster randomized control trial in all 9 intervention countries. And we're still in the process of analyzing the final outcomes here. And before the end of the year, we will have a final optimization phase to improve the MENTUPP Hub resources for wider implementation. And that process will start from early on in the new year. Very pleased to present the leads of the 10 work packages in MENTUPP. I'm not going through all of this today, but you will meet some of the leads here today. The methodology of MENTUPP and building the MENTUPP Hub was very much designed in terms of 10 interdisciplinary work packages, very specifically aligned with the specific objectives. I'm also very pleased to say that we have a strong advisory board, interdisciplinary and internationally, which is a must when you're facing a challenge such as putting in place such a project. I'm very pleased also with the support from IOSH and Dr. Karen Michell over many years. A few pointers about the rationale in relation to why did we choose for the work sectors construction, healthcare, and ICT. Across these 3 health sectors, it's become clear already before COVID that there were high levels of absenteeism and presenteeism. When we look at the construction and the healthcare sector, there's been high levels of mental health conditions, but also self-harm and suicide. For the ICT sector, rapid changes, high levels of absenteeism also represented a very important rationale. Now, all of this was developed prior to COVID, and as many on the call probably also know and can assume that many of these mental health conditions further exacerbated during and after the COVID pandemic. And some of you here may be a bit surprised to see the healthcare sector, because you may think this is a bit paradoxical, but already over the past decade, research that we have conducted consistently highlights high levels of stigma and also high levels of mental health conditions, particularly also in the healthcare sector. Another unique element of MENTUPP and the MENTUPP Hub is that we went for a truly multi-level approach. So the resources in the MENTUPP Hub are not only tailored to the 3 different work sectors, but also tailored to the employees, group level leaders, such as supervisors or health and safety officers, and the managers. So for everybody in the organizations, there are designated resources. I'm also very pleased to say that the MENTUPP Hub and the numerous modules, resources in the MENTUPP Hub are evidence-based, based on multiple systematic reviews that I would recommend you to access. They've always been they're open access, published peer review articles. In addition, we did a very thorough consultation with experts, but also employees, for example, in the different work sectors. And we also have a strong theoretical underpinning of the elements of the MENTUPP Hub. And as you can see, in terms of that important distinction between non-clinical and clinical mental health conditions, that was also provided the basis for the different resources as part of the MENTUPP Hub. This is just the front page of the MENTUPP Hub, and later on in the menu in this webinar, we will take you briefly through the MENTUPP Hub by a video. But as you can see, obviously all relevant sectors are represented here. This is just a sample of the different modules, sessions on the basis of which we have built the MENTUPP Hub. So it covers various aspects related to mental well-being, stress and burnout, stress management, specifics on depressive symptoms and clinical depression, anxiety symptoms and clinical anxiety, but also aspects in relation to coping with mental health difficulties in the workplace, or coping when you become aware that a colleague may be experiencing mental health difficulties in the workplace. As Karen already alluded, we are coming to the end phase of this very large scale and long project. So the end phase is December. I'm very pleased to say, and with huge compliments to the team, the MENTUPP team, we've made it well through the COVID pandemic, but we had to transfer all our plans in terms of on-site, in-person interventions to online. So that constituted the MENTUPP Hub, the online MENTUPP Hub. Whilst we knew that we almost had to sacrifice some of the in-person elements, we worked very hard in the MENTUPP Hub to have proxies for interactive elements, interactive sessions, but whilst being on the online MENTUPP Hub. I would invite you to access some of the multiple peer review articles that have been produced by colleagues in the MENTUPP Hub. So a number of specific tailored systematic reviews to the different work sectors, but also very pleased to say that just over a week ago in BMC trials, the detailed trial design of the cluster randomized control trial of the evaluation to test the effectiveness of the MENTUPP Hub was published, which may be very relevant for people on the call today. So on this note, thank you again for attending this webinar. And I'm pleased to, if people have questions, happy to answer that later on. I'm handing over back to Karen Michell. Thank you.
Thank you very much, Ella. Okay, so let me move directly into our next speaker. And our next speaker is Professor Ulrich Hechel, who is president of the German Depression Foundation. He leads the German Alliance Against Depression and is president of the European Alliance Against Depression. For more than 30 years, he has been strongly committed to paving the way for better research and education about depression and suicide prevention. He has extensive experience in the treatment of mentally ill people and was clinical director of the clinic and polyclinic for psychiatry and psychosomatics in Leipzig until March 2019. He has published over 650 articles. As founder of the German Alliance Against Depression, he developed a 4-level approach to improve the care for people with depression and to prevent suicidal acts. This approach is now the most widely implemented community-based approach to suicide prevention worldwide, having been adopted by partners in countries such as Europe, Chile, Canada, and Australia. I also just want to introduce at this point Stefan Hachel, who will be joining us for the question and answer section. Stefan has been working on the IT for the European Alliance Against Depression and the German Depression Foundation and suicide prevention since 2020, on numerous projects, including MENTUPP. He has played an integral role in the development of the MENTUPP Hub, which will now be explained. Thank you very much. Over to you, Ulrich.
Thank you very much, Karen. Concerning the content of the hub, of course, all partners have contributed, and Stefan Hackel, who will move forward the slides and is sitting in a different place, was mainly responsible for the IT aspects of setting up this hub. It was a process in 2 phases, because first we had a pilot, and based on this pilot experiences, we were able to optimize the hub. We made more visuals. We had feedback from an e-learning expert. Please go on, Stefan. And of course, we had to translate it in different languages. These are the language versions which are available. At present, we have added an Ukrainian version. Please go on. And several other aspects which had to be improved. The registration process was made more simple and more easy to handle. The navigation also, personalization is now possible, so you can adapt the hub according to your preferences and your needs, and the responsiveness has been improved when used with mobile devices. Next, please. Finally, we came out with this basic structure. Again, there are different modules, and they are organized according to our 3 main teams. Ella has mentioned this already. First, the more non-clinical or sub-diagnostic aspects, stress, mental well-being in general, burnout, and the area B, which are real disorders. And we felt it's important not to mix it up because there's not a continuum from stress to disorder, but these are really quite independent disorders: depression, also anxiety and suicidal behavior. And then another topic, an overarching topic, is stigma, which has a lot of negative consequences on the suffering of people with mental disorders, and also on help-seeking behavior. So this was the area C. And then there has been an extra module dealing with the COVID-19 pandemics and related stress symptoms. So topics which are addressed, you can see here: what is mental well-being, what is stress, what is anxiety, what is depression, a toolkit to support each other at work, and several other elements. I think you will hear about it later. And some elements are general elements, but other are also country-specific. For example, help links, you have to adapt it country-wise. There are also role-play videos and downloadable information, audios, animated videos. So a lot of material has been developed within this ambitious project. So now, Stefan, I think we make a short tour through the hub. Perhaps we can make it a little bit louder. Okay, this was only to give an impression how it looks like and how it's organized. So I think this was our short presentation of this aspect. And thank you for listening. And if there are questions, we are happy to answer.
Ulrich, thank you very much. Very informative and such a lovely clip of the MENTUPP Hub as well. Right, so let's move on. I'm now going to introduce Chantal. Professor Chantal van Oudenhoff specializes in implementation research in care. Her research aims to improve settings in care and welfare organizations as well as policy. Collaboration with important stakeholders is part of the methodology in this approach. She is a partner in several international research consortia, such as MENTUPP. The main focus of her research in mental health care is on the prevention of depression and suicide, quality of mental health care, as well as the evaluation of mental health reform towards community mental health care. Burnout and work-related mental health problems, as well as participation of persons with severe mental health problems in work, are an important focus in several of her studies and publications. Chantal, we welcome you.
Hello, everybody. I'm trying to find the start of my presentation and to open the screen. Yes. Thank you, Karen, for the nice introduction and for coaching us. And I will present the evaluation of the pilot. That was the work package of KU Leuven, together with my colleagues, Eveline and Fotini, and the whole MENTUPP Consortium. We prepared the evaluation of the pilot. And this is also at the same time the preparation of the evaluation of the clustered randomized controlled trial. In this, so try to move this, yes. As you have understood, this intervention is a very complex intervention. There are several interacting components, very different target groups, and it is implemented in different countries, different sectors and organizations. That means that the standardization of the implementation is also a big challenge. And we had to evaluate process and outcome. And we base this also on the RE-AIM framework. And this is a framework that is used very often for implementation research, where we look at the reach. Do we reach the target group that we want to have in this study? How can we measure the effectiveness in primary and secondary outcomes? Is it adopted by a representative group of SMEs and employers? And is it implemented as it is foreseen and described? And is it maintained during the time, also probably after the research is finished? So all these questions come together in this one study, and we used a mixed method design. As you see, we prepare a clustered randomized controlled trial where we will recruit in 54 SMEs in 9 countries and 6 SMEs per country. And that means that 2 in construction, 1 in the control group, and 1 in the intervention group, and the same for health and ICT, with measurements of baseline, implementation, and follow-up. So the evaluation strategy for a clustered randomized controlled trial in such a complex situation should be simplified. And you understood that there were different groups of colleagues preparing reviews. And in these reviews, they had also a lot of insight on the effectiveness of several interventions, on which also the hub was based. But that means that we had to set priorities in a scientifically responsible way. It was not possible to take all these effects, all these interactions in our research, in our evaluation. And the Medical Research Council also recommends to work on a theory-driven approach. And this was what we wanted to do in the evaluation work package. So the theory-driven approach, it means that we want to understand how and why MENTUPP has a particular effect, to explain also the mechanisms of the change within MENTUPP during the intervention, make also underlying assumptions explicit, and take into account the implementation aspects. So we wanted also to acknowledge the role of the wider context, the SME, the sector, the country, and also the COVID measures that were present. So for that reason, we decided that it was interesting to develop a theory of change. And a theory of change is a dynamic and flexible theoretical basis for the research that is not the same as a simple theoretical model that is normally used in research. That's more static, rigid, basic, and simple, linear. And as I already said, we couldn't bring all the reviews together, then we would have too many aspects without taking into account the complexity and the theoretical basis of the complexity of this context, which is non-linear, because several factors are interacting with each other. Theory of change is well described in literature. First, it was relatively new. It was, we thought, useful for the evaluation of this complex intervention. It helped us to identify the right indicators and select better evaluation measures. And it's used more and more, but there are not yet so many good examples, although we found some examples that have inspired us. Meanwhile, this theory of change is also published. You can find the publication about it. And we define it as an approach which describes how a program brings about specific long-term outcomes through a logical sequence of intermediate outcomes. The assumptions about what needs to be in place for the theory of change to occur are made explicit, as well as contextual factors which influence the theory of change. So this is the picture of the theory of change that we have developed and that is published. I cannot go into the details in this short period of time, but you see that it is compact and targeted as an evaluation approach. And there are specific aspects, requirements for the implementation that are the point of departure. Then there are proximate outcomes at the level of the employees with knowledge, attitudes, and skills, also at the level of the leaders. And you see that they have intermediate outcomes that are more on the level of the workplace factors, and long-term outcomes are also defined at the level of mental well-being, reduced burnout, reduced illness, reduced mental health stigma, and also reduced productivity losses. Not to forget, also the economic aspects are integrated in this model. And of course, in the end, we will not change everything at the level of mental health promotion in the workplace, but it is our ambition to have some impact, and it can have a ceiling of accountability. It will be limited, but we also will try to describe this, which is one of the main ambitions of our whole MENTUPP program. For the evaluation of the pilot, we came together several times with all the researchers, and we developed a strong collaboration in which we brought all our knowledge together to make the best choice on the assessment of the evaluation instruments. It was not such an easy task because we started with a lot of inspiration, and we managed to find consensus on a methodological way by looking at the reliability, the sensitivity, and the validity of instruments that were proposed, and we tried them out in the pilot. It was a mixed method design in which also some qualitative data were integrated. We had focus groups also with employers, employees, and research officers. There was a monitoring of the implementation, and also the data of the hub were analyzed. And these instruments were also used as a test phase for the clustered randomized control trial. Based on the data that we gathered, we could make choices for the next stage of our research, which is not presented today because it's not finalized. In the pilot, we had data gathered in all the countries. You can see it here, the overview. And you see that in total, we had in 25 SMEs, 1,219 employees were present there. And the number of employees that were completing the service in the first time were 364, and at the second assessment, 92. It was difficult to convince in construction and health to participate. Also, the COVID-19 was a very disturbing factor. We reached 209 of the 1,219 recruited employees. They registered for the hub. It's 17%. And the reach differed across sectors and countries. We explored the uptake in the pilot study, and we found a time gap before getting access to the hub. There was a low engagement of leaders due to the COVID-19. They had other priorities. Some employees were not intrinsically motivated. Some extra push was necessary on the working floor. There were some stigmatizing attitudes. There was a misperception, for example, that only for people with mental health problems, this was necessary to use. It was rather time consuming, also a big issue on the working floor. For the economic aspects, this was a point of attention, and we took note of this also for preparing the cluster randomized control trial evaluation. The work pressure and the stress. Teleworking was also a factor. There was lack of face-to-face contact and on-site support, and at some places limited technological infrastructure and skills. So you can see that all these points are points for improvement that we took into account for preparing the clustered randomized controlled trial. Then the strengths. There were various topics and formats. There's something in it for everyone. We learned in the focus groups. It's helpful to increase awareness and to understand mental health, to create openness, to talk about mental health difficulties, and to detect warning signs and mental health problems. No prior diagnosis was required to access the hub. It's also seen as a strength. One can visit it at its own pace, confirm the personal interests, and it is especially suitable for ICT because they're very technological literate. Some barriers, the structure of the hub required some rethinking, which was done, of course, for the next phase. The content of the hub is for some people too theoretical, too difficult, textual, and voluminous, and it was less suitable for construction. There also, these lessons were taken into account. Then, when we look at the results that we could analyze from the scales, we saw some promising results on the mental well-being, on the symptoms of anxiety, and on the stigmatizing attitudes towards depression and anxiety. We saw no significant improvement for other topics like symptoms of depression in the PHQ-9, presenteeism and absenteeism, burnout, and attitudes towards seeking help, and a reversed effect of psychosocial risk factors and stressors in the workplace on the COPSO. So we have, of course, to take into account that we have only a small group of people for which we have the follow-up data, which is very limited, and that these are only preliminary research, although we were happy with the first insight on some improvements. So far, a brief overview. You can find a lot of information in the publications that are already ready from the work package evaluation, and where you can find all the details of how it was managed. Thank you for your attention and curious for your questions.
Chantal, thank you very much for that very insightful and very clear presentation. So it now comes to me to introduce our final speakers, but by no means the least of them, and that is Professor Margaret Maxwell. Margaret is Professor of Health Services and Mental Health Research at the University of Stirling and took up the post of Director of the Chief Scientist Office funded Nursing, Midwifery and Allied Health Professions Research Unit in 2016. Now there's one that needs an acronym. As director, she has a long-standing interest in developing research capacity and capability within the NHS, the National Health Service for non-UK attendees, workforce to enable delivery of evidence-based care. She's been involved in health services research for over 30 years, focusing on quality and delivery of care and common mental health problems. She has been involved in several European research collaborations, tackling suicide, depression, and mental health in the workplace, and has evaluated several national programs for improving mental health, tackling depression and psychological distress. Margaret, thank you very much, and over to you.
Thank you very much, Karen. Good afternoon, everyone. I'm going to be presenting on the systematic review that we conducted to help guide the MENTUPP intervention in relation to implementation. So we wanted to look at what do we already know about implementing mental health promotion interventions in the workplace, and how can we take that knowledge forward into our own implementation of the MENTUPP Hub in both the pilot and in the cluster randomized controlled trial. So my aim today is just to review the evidence that we found in relation to the implementation of mental health programs in the workplace, because I think this knowledge is relevant to everyone who wants to undertake implementation. So we'll share what we found with you. As Ella had mentioned before, we have had a few publications from MENTUPP already, and one of those is the protocol for the systematic review that I'm about to present. So there's more detail there on the methods if you want to have a look into that. And apologies in advance for quickly rushing through most of the methods for this. I wanted to get on more to presenting some of the interesting findings and what we did with those in the MENTUPP project. So the review wanted to look at what evidences there are out there already about implementing mental health promotion interventions, and specifically looking at barriers and facilitators for that. And we conducted a review looking at years 2019 up until August 2022. And we hope that this review would develop an increased understanding of factors influencing successful delivery of mental health promotion interventions in the workplace. We had a few research questions for our review. So the first aim was actually to see what knowledge is out there and what's the scope of that knowledge. So the first research question related to a scoping review in terms of what can we find out. And then we wanted to delve a bit more deeper into that to look at barriers and facilitators in general in terms of mental health promotion interventions in workplace settings, but then also more specifically what barriers and facilitators could we already know about in relation to small to medium enterprises in particular, and then also in the three sectors that we're interested in for MENTUPP, so the ICT, construction and healthcare sectors. And for this much more in-depth look at the literature, we sampled what we referred to as data-rich articles, so mostly qualitative evidence, although we did look at other studies which may have reported in-depth qualitative evidence within them. And we looked at answering our two questions using qualitative evidence synthesis methods. So just to give you an overview, we have the Prisma flow diagram here about all the efforts that we went to, not just to identify studies published in databases and registered, but we also looked at grey literature resources as well, knowing that there may be other types of reports out there, and we brought that grey literature in as well as the published evidence. And overall, we identified 43 primary studies eligible for inclusion. And that really is the overview of the scoping review, really, for those papers. And then looking much more in depth at research question 2, we found 22 articles there. And then research question 3, which is our much more specific, let's look at SMEs in particular and the 3 sectors that we're interested in. We found 16 articles related to healthcare, 5 related to SMEs, but only 1 for construction and ICT. So that identifies quite a gap in the literature there as well. We looked at Nielsen and Randall's model of organisational level interventions to guide the analysis of that qualitative evidence synthesis that we were conducting to look at all the barriers and facilitators. And that really is looking at context. It looks at intervention design, and in particular, we're looking at intervention activities and implementation strategies that were out there that could help guide us towards improving further implementation. But also it includes mental models as well, you know, people's readiness for change and perceptions of intervention activities and any changes in those mental models. And looking at research question 2, so this is related to looking at barriers and facilitators that are out there in the literature in general, where we had 22 papers. We have graded this evidence, so it's green, amber and red, and green is referring to data where we have a high level of confidence in the findings. So there were many of those 22 papers which referenced intervention content as being very important in terms of intervention activities. And again, when we look at implementation strategies, management buy-in and support at all levels was really important. So I think you will probably see some very familiar or at least expected areas where we have very strong evidence for those findings. So we all know that change agents and champions are always very helpful for implementation, and that is very common as well. So you can see that we've gone through the Nielsen and Randall model of intervention activities, implementation strategies, context, and mental models to highlight what are the key findings and which ones we have strongest evidence for, medium level evidence, and a bit lower level evidence for that. So I'm not going to read out every level of detail there, but you can see content, management buy-in, change agents, having resources for plenty of staff time to implement things, but also experience of mental health already within an organisation is a good motivating factor in terms of mental models. And of course, stigma and perceived issues around confidentiality can be a barrier to implementation. So if we look at the research question 3, which is where we were looking much more specifically at either SMEs or the 3 sectors that we were interested in, and the area where there was most evidence was in the healthcare sectors. And there are slightly different findings here. So in terms of the healthcare sector, what we had much more evidence for was the importance of the accessibility of the intervention to healthcare workers during their busy day-to-day routines, but also fostering relationships, openness and confidentiality. So it's really important for healthcare workers to feel that they can open up about mental health and well-being with their colleagues, and that there is a kind of a supportive context there for them as well. Similarly, there's the management buy-in is really important for everyone, but clear communication in relation to the intervention was also really important for healthcare workers. And another one of the differences that we have is previous experience of interventions and training for mental health, but also the perception of the intervention, the perception of, will this intervention likely work, likely make a difference, influence the uptake of that in the healthcare context. So we had 5 papers relating to SMEs in general, and you can see from this that we, because of the lower number of papers and the way the studies were conducted, we have what we would consider high level or high confidence in the findings. It's much more in terms of the medium and lower level evidence here. But again, we can see there are quite a few generally similar to the previous findings, as we have found both in the literature in general and also within the healthcare sector there. Intervention content, fostering relationships, these have already come up within the previous 2 slides. And the perception of the intervention is also relevant, comes up as relevant within SMEs as well. And as I said, we didn't have any evidence or enough evidence to look at the specific sectors of ICT and construction. So what we did with this in the MENTUPP study was to prepare a 2-page document for our sites that would be implementing both the pilot and the main RCT. And we gathered the findings into this, what we called implementation considerations. And one page was presenting the findings, and the other page then put some reflective questions to the researchers and the teams implementing MENTUPP in those sites. And this is just highlighting an example of the types of questions that we had people reflecting about. So looking at, we've heard from the literature that leadership buy-in matters. So we pose the question, in what ways will leadership commit to support the intervention activities actively and continuously? So the implementers of MENTUPP could actually target some activities there. To promote encouragement, it's about how will we encourage promotion efforts from both within our study itself, what kinds of prompts and notifications will we give, and then externally as well, what kinds of efforts to promote MENTUPP will occur with outside of the research team, but internally within those SMEs. So that's just an example there of how we turn that evidence into activities or areas that the implementers could pick up and really target to make sure that we were improving the implementation strategies within MENTUPP. So I think that's all I want to say about that. And obviously these documents are available for people to access and have a much more detailed look over as well. And we have submitted our publication to a journal, so we hope that that will finally be published as well, the outcomes of the systematic review. Thank you.
Thank you very much, Margaret. So thank you all to our presenters. Can I ask you all please to put your cameras on and possibly to unmute yourselves, unless you remember to unmute yourself when questions are posed. We have a fair number of questions in the questions and answers block from our audience, and we have used the upvoting system, and I'm now going to tackle those based on the responses of what people would like to see answered. So let me start with our first question comes from an anonymous attendee. Regarding the increase in mental health disorders during the COVID pandemic, how much of this is expected to be a direct cause of the pandemic as opposed to an increase in reporting from workers having more time and energy to potentially take a step back and acknowledge their own mental health? I'm not sure who would like to take this one. Ella?
Yeah, no, it is a good question, and I don't think we have a full answer to that yet. But the first point maybe to make is, yeah, based on an extensive number of studies now that commenced during the first phase of the COVID pandemic, second phase, and then also more currently, studies being published. The hypothesis that COVID itself or also certain restriction measures caused an increase in the incidence of mental health conditions doesn't seem to be very strongly supported. There is more consistency in terms of people in the workplace with pre-existing mental health conditions, even with mental health conditions that may have improved, that COVID and also some of the public health measures may have further exacerbated some of those mental health conditions. Now, the interesting point that was made, would people when they were working from home or in quarantine or working less have been more reflecting on possible mental health conditions? That maybe a likelihood to some extent, but I'm still then thinking of not a direct causal link between COVID and those mental health conditions, but already some aspects maybe existing beforehand. Obviously, what we have come across the health sector, some extreme situations where people lost multiple colleagues, also then had increased anxiety in terms of their own safety, reduced supervision and so forth. But overall, people who were mostly affected were certainly people who already had a certain level of mental health conditions before the COVID pandemic. That still underlines vigilance now, and maybe even still for the years to come, because we still don't know enough about the long-term COVID impacts.
Thank you, Ella. I'm wondering if maybe Chantal or Margaret can address this one. Again, from an anonymous, have you found themes or common reasons of work-related stress or non-clinical depression and burnout, apologies, and if so, what were these? Margaret, do you maybe want to take this one?
Yeah, we haven't specifically explored the reasons behind people expressing that they have experienced stress or burnout. I think that that's a different kind of systematic review in that sense. But I think from what we know about the prevalence of these in the workplace, is that they are quite common experiences. And very often it can be the work environment itself that is causing this. And that's been the focus of what we've tried to look at, is within the work environment itself, because there can be many things going on in people's lives in the background, but we were specifically focusing on what are the issues within the workplace. And very often time pressures on people are one of the things that come out very, very strongly. And that's across all of these sectors, whether it's construction, healthcare or ICT. Everyone is working under time pressures, and there isn't always that understanding amongst colleagues either if you are having difficulties in working within that environment. I don't know whether one of my other colleagues wants to say some more on that.
Yes, I want to agree with you, Margaret, and I also think that's why we also have a big eye also on the leadership style, and we hope that something like that will also come out of the clustered randomized control trial, because the culture of an organization can create an openness for people who are mentally weaker or have specific needs, or can go against the stigma and things like that. So, from the pilot itself, we didn't have only hypotheses. We did not have these results.
Thank you both very much. Then Chantal, I'm going to pose this next question to yourself. One of the questions is about the psychosocial findings and the fact that there was significant reversed effect of psychosocial risk factors. And the question is, do you have a possible explanation for the fact that you saw this finding in the study?
No, we did not have it. We were very, a little bit surprised by that. But yeah, it's only a pilot. And I don't have an answer on that. So I think we were, wondered.
Yeah.
Ella, maybe you have an answer.
Yeah, I don't have the answer, but in some of the discussions, and also looking at some other projects globally, with not the same, but there's no exactly the same intervention. But what we have seen, certainly in work settings with high, you could say above average levels of stigma, that when people became more aware of certain psychosocial stressors or adversity, that they also reported this more. So it's that becoming more conscious of adversity within the workplace. Whereas when some of those educational or clarifying resources were not there, people just didn't know where certain stress came from, or just sometimes it's management, it's always management or so, but not being as perceptive after having gone through some of these resources in the MENTUPP Hub. But okay, that is hopefully something we can then definitely further investigate in depth with the findings from the cluster randomized controlled trial.
I'd just like to support that, and I say and say that I think as occupational health professionals, both from the safety and the health side, that is the psychosocial side is something that I think has been weakly addressed, because it's one of those not so easy to address it and get it right. So yep, very much. The next question I think is a general one, and one that a lot of people have a problem with, and it's based around recruitment of participants into mental health studies. And they say that it remains a challenge. Have you learned any lessons from this study that might be helpful for other projects in the future? Who would like to address this one? Margaret?
I don't mind starting. One of the very unique things that we found in our own study here is that actually our control sites have been much more amenable to completing all the forms and actually actively taking part. And I've never come across this in many other trials ever, certainly that I've been involved in. So that's quite unique, and we have pondered on that ourselves, because there must be lessons to be learned for that about how you can recruit. And I think, you know, part of it is separating what are the activities for engaging with the intervention itself, and what are the activities that are associated with the researching of the intervention. And I think because the intervention SMEs had dual tasks, so they had to complete our information for the research purposes, but they also then were completing the hub and going on and looking at the hub. And it may just be that both activities combined were perhaps just a little bit too much for them, and therefore we had less active participation in those ways. The control SMEs, who are completing our instruments with the promise of access to something, there was an incentive there to access something that they think that they're currently not getting. I think that encouraged them to stick with us and complete our pre and post questionnaires and follow-up questionnaires. So that's been really, really fascinating. Of course, we know all the same things as well, that, you know, a whole workplace that's really enthusiastic about an intervention will and encourages people to take the time, and time within the working day being allocated to allow them to complete measures. That was really, really important in this study. And we engaged in a lot of activities to try and encourage that. So we know our researchers were there at times with coffee and donuts to try and encourage people to fill out questionnaires there and then on the day. So we tried lots of activities like that.
Ella?
Yeah, these points by Margaret were absolutely excellent. Just a few additional points which we haven't yet been able to verify completely quantitatively, but just in working with the SMEs, there was very good engagement with management, but also health and safety officers, for example, and overall also employees in workplace settings where there was some experience with employees who suffered from mental health conditions, or for example, where recently, very sadly, a suicide had occurred. So suddenly the interest and the motivation in having an integrative mental health support resource in the company on the workplace was greater, was enhanced. Also, the early stage engagement. So we did engage a lot with management at an early stage. We had specific introduction sessions but also guided by interdisciplinary steering groups. So in all the 9 intervention countries, the work was informed and supported by steering groups with the relevant representatives on board and people, including obviously employees also themselves. And a last point that I can think about is then visibility, but not in a tokenistic way at all, but overall management did appreciate that if they were participating in MENTUPP, that it was also visible via being able then to refer to a certain logo. So that they say, okay, this company supports a positive mental health promotion approach in a genuine way. And yeah, they felt that was a kind of also a positive trigger, and they felt very much facilitated. Oh yeah, and the very last point is this was EU funded. Now in the future there will be a fee attached to the MENTUPP Hub, but certainly for some companies struggling with economic challenges, the fact that the EU funded this resource and there was not a specific huge fee for them, for the company, was also an advantage.
Thank you. Chantal, do you want to add something?
Yes. On the question, yeah, what did we learn from it? I think that, yeah, knowing what we see, that there is a lot of dropout in the iterative assessments. We were focusing as researchers also on solving the problem by using imputation techniques, which is specialization in statistics, to help us make the best out of the results that we have. And I think we also learned a lot about that as researchers, which might also be helpful in the future when we cannot solve the problem by doing what was already said by Ella and by Margaret.
Thank you very much. And I think that leads us quite nicely into another question that's been raised, that I know that a lot of the study has been done in what would be labeled high-income economies. And the question is, what are the considerations for implementation of the findings in low and middle-income countries? And Simon's specific request here is, for example, that he's working in rural northern part of Ghana as a mental health professional, where we know resources would really be stretched.
Mm-hmm. Yep. Very good question. And also this is something we will be thinking, well, we have been thinking about already a lot, but certainly with the upscaling and moving into 224, that will be obviously very important. We have obviously so far not implemented the MENTUPP Hub in low income countries, but obviously we are working with middle income countries. Overall, the uptake and the interest has been high in those countries, and don't have the full explanation here, but there were workplace settings where never any attention was paid to any mental health promotion or even any communication about mental health and well-being. And there were reactions that I would interpret as management and to some extent employees embraced the opportunity of now finally having access to a resource like that. Again, after the CRCT findings, we will know a little bit more about that. But when I look at other projects internationally, in the current times, when you deal with sessions or sectors or target groups where never any resources have been presented, there seems to be a relatively greater interest and greater uptake.
Thank you. This question, I don't think we have the answer to this, but did the study look at an age breakdown within the organization? So the age of the respondents. Anybody? Chantal, you maybe want to address that one. So I think the question is along the lines of, is there a difference between younger workers, older workers, etc., in terms of the findings?
And I don't know if other people have this in their mind, but I don't think we have this as an effect in our results. But also we didn't look at it very specifically because yeah, it's not directly yeah, something in our yeah, in our first ideas or hypotheses. But it could come out when we do the analysis of the clustered randomized controlled trial data, where we have a more large sample. And yeah, it doesn't make sense to do too many analyses, except if there are specific hypotheses which could be there, that maybe younger people are more attempted to be open about the topic. That could be that in their culture that could be a difference, maybe. But yeah, we didn't really look at it. Ella, maybe you have some ideas about it.
Yeah. No, on the basis of the pilot study, statistically, we could not look at that in terms of not having obviously the sufficient numbers. For the trial, we could look at it to some extent, maybe look at some subgroups based on research that maybe not so recent, but that was one of the driving forces behind developing MENTUPP and the MENTUPP Hub. When we look at the area of burnout and stress, there have been consistent indications of an increase in younger populations, younger groups of healthcare workers or apprentices. So that could constitute an important hypothesis for us to look at that when we have all the data with us to analyze for the cluster randomized controlled trial. In the team in Leuven with Professor Van Oudenhoven, we have looked at gender differences, but again with the pilot, the numbers were not maybe significant enough for the trial. We will certainly be doing that. Yeah, but it is, I mean, it is on our minds, but you can only go to subgroups when you still have sufficient numbers. Yeah.
Thank you.
As far as I'm aware, in terms of interventions, interventions don't often specify an age group because they don't want to be discriminatory or exclusionary in terms of who they reach. So there's very little there, I think, in the evidence that would guide us in relation to differences. But I think Ella's point that, you know, younger people tending towards feeling much more stress and burnout is something that we could look at.
Okay, well, we literally are down to our last 2 minutes. Some very good questions and responses there. So I'm going to ask each of our speakers very quickly, if you have one key take-home message for our audience today, what would that be? Shall we start with Margaret, since you're on the screen?
Yeah, I think my take-home message is that actually there is at the moment, there's a lack of evidence for implementing mental health promotion interventions, particularly in small to medium enterprises, and especially in the construction and ICT sector. So I think good to have more efforts there.
Thank you. Chantal?
Yes, I think that the work that was done by bringing together so many results from research in one theory of change, I hope that this approach might help people to look in a more thorough scientific evidence way to these complex situations, that it broadens the view, the perspective from very linear ways of reflecting on theory-based evidence to really integration of as well the individual, the organizational, and the more high-level aspects of a complex situation concerning mental health and well-being.
Thank you. And Ella, final word to you?
Yeah. which I start with a reflection. So, because we're coming closer to concluding MENTUPP, but we will be moving on with other major projects building on MENTUPP. But if I reflect back to the huge challenges that we had in the first months of COVID, because even though we always had on our radar that we would work towards online resources, initially we had said we would like MENTUPP to have a blended nature, because blended has shown to be producing the more sustainable effects. And despite the huge challenges over a long time in working online, even as a team, but also working online with all the SMEs, which eventually we've succeeded, and we have succeeded quite well. But then people say, well, how did you do that? Now, and I look back, then I would say, if we wouldn't have had that truly interdisciplinary consortium, and also obviously we had some excellent advisors with us, but if we would not have been so interdisciplinary as we were, we wouldn't have achieved some of those challenges to transfer so many resources and so forth. So to take home, if you want to achieve something like a multi-level intervention at level of mental health promotion, suicide prevention as well, you need a truly interdisciplinary team. Yeah.
Thank you very much. So to our speakers, I would like to express my sincere appreciation for the time you've taken out of your very busy schedules to participate today, and also to the audience. And I trust you find the insights today helpful, and that we all feel a little more confident in assisting those workers who need our support in their battle with mental health issues in the workplace. And until next time, goodbye and thank you.